and welcome to our 50th season of Basic Black. Some of you are joining us on our live broadcast, and others are joining us on Facebook Live. Either way, welcome. I'm Tina Martin from WGBH News. Callie Crossley has the night off. Joining me tonight are Dr. Christine Crawford, a child psychiatry resident at Mass General Hospital and McLean Hospital; Kwame Dance, a clinical psychology doctoral student at William James College; Dr. Xenia Johnson Bhembe, an adult and child psychiatrist at Cambridge Health Alliance. Dr. Bhembe is also an assistant professor of psychiatry at Harvard Medical School; and Carolyn Reynolds, mental health and substance abuse therapist at Whittier Health Center. Welcome to all of you. Thank you so much for joining us.
Thank you.
We appreciate this.
Thank you.
So let's start the conversation about mental health in communities of color and why it's a different kind of conversation than other communities. We'll start with you, Dr. Crawford.
Yeah, I think what often gets in the way of starting a conversation about mental illness in communities of color is the fact that it's hard to start the conversation. And I think a lot of it has to do with the fact that people rarely talk about mental health related issues. Oftentimes people feel comfortable talking about when they have high blood pressure or diabetes and when they need to go and see the doctor, but you rarely hear people in our community talking about seeking out treatment for depression and what it's like to see a doctor and to initiate that conversation. And I think that I'm really happy that we're having this conversation right now because oftentimes we don't really have it with our family members, our friends, and our own community.
Right. And just to pick up on that, I mean, as the only male on this panel, it's kind of, you know, we men, we just don't talk about our health issues at all in the Black community. And I think that impacts just how we approach our work. Even the way I am with my male clients, my Black male clients, is very different. Just because we have to normalize the process of seeking mental health treatment. So it's tough.
I think a dimension to this too is that the Black community has had a problem with vulnerability in the first place. In a society that has seemed to really prey on its vulnerability, it's hard then to discuss vulnerability to the world when you felt like the world may actually have been a threat to you.
Exactly.
Particularly for communities of color.
Right. And also, I think the miseducation and not understanding what mental health is. A lot of stigma around thinking, well, you must be emotionally unstable, you know, and you're not strong, you're not weak. How come you just can't snap out of it? And understanding the gravity of the situation and life circumstances, no, I can't snap out of it. And then that shame factor, you know, and then how we keep things a secret. We don't want to share if there's trouble in the family. We want to present ourselves that everything is fine, everything is perfect, and we have it all together.
And so how do you get past that where you say there's obviously a difference between feeling a little down and having a clinical depression? And so when someone comes to see one of you, what is your process to kind of break that down and determine that there's something medically going on?
Right. Well, we all have our down days, right? And I think that's what you mean. But depression and other mood disorders are something different. And we use our DSM, our Diagnostic Statistical Manual, to formulate our diagnoses, but it's based on the amount of time that a person is experiencing the symptoms, and you can really see the difference. Sometimes it's not as clear cut, and sometimes symptoms present differently with people of color. So it is important to be competent in that area, whether you're whether you are a Black clinician or not. You need to be competent and be able to recognize the signs and the differences, I'd say.
Kwame makes a good point, because especially I find with African American females, our depression can cause symptoms of physical symptoms, elements like my back hurts, I'm having pain in my body, or I'm having migraine headaches. And that can be misdiagnosed as saying that it's a physical ailment, but when you start peeling back the layers, you find out that they have some circumstances going on in their lives that's causing them the depression, and the depression untreated is causing these physical ailments.
And there's also this element of function. Like, I feel like at the heart of all of it is your capacity to function, and function in your work life,
Yes.
working in your personal life or interpersonal life, to function against adapting to different changes, and then how you manage just adversity that comes to you. If you find that you're stumbling in those functional areas, you can key into that as being a potential diagnosis that has a medical cause.
And so the stress, let's talk about stress and mental health. Those two often go hand in hand. You know, talk to me about how you deal with people when they come to you, dealing with those two different things, because sometimes they're, I would imagine, sometimes they're the same, from the same, the same thing going on, or something different, two separate issues.
Right. It's really important to be able to get to know the client a little bit better, so that you have a better understanding as to what it is that they're describing as stress, or what it is they're describing as depression. And oftentimes, people of color, they like to use stress as a way to get in, because that's a safer experience that everyone has been through. But as a clinician, what I really listen to is the amount of time in which they are dealing with the stress and how they're dealing with it. You bring up a good point about the level of function. So if I hear about someone who's not able to sleep well, they're not able to eat, they can't concentrate, and they're having thoughts of feeling hopeless, and this has been going on for more than 2 weeks at a time, then I'm starting to think a little bit more about depression, because of the way that the symptoms present and how long they present for. Now, stress, that's something we experience as humans day to day, and that varies. But when I hear someone that says, oh man, I've been stressed for a month and I'm losing weight, that's different. But day-to-day stress with driving in traffic, that's to be expected, but we really need to educate our community about what the difference is between the two.
I think there's a way in which I think our community could benefit from understanding the distinction about sort of normal stresses, like we've mentioned, and then the biochemistry or the biological basis of disease that goes on in mental health disorders. And there is a distinction, and we have biological data now to point to where these disease processes are actually chemically based. And oftentimes people don't want to hear about chemical imbalance, but that's true. It's sort of a medical entity. It's just like diabetes, it's just like hypertension, it's just like rheumatoid. Anything that you might be able to treat medically, mental illness is the same.
Right.
And I think that comes back with education. It's important
Yes.
to educate our community about mental health and what it is.
Yes.
Mental health, like you just said, is also the same diagnosis as a physical ailment, but my mental health can be affecting my physical health, and my physical health can be affecting how I'm feeling. And that, like diabetes or high blood pressure, can be treated with medication. Well, mental health symptoms can be treated as well with medication, but it doesn't have to be lifelong, and that's another barrier. They feel that, oh, I may have to take this, the rest of my life, or what is this medicine going to do to me? I'm afraid to take this medicine because I'm not really trusting that you sure this is the right medicine for me. So I think it comes back to listening to our patients and what they're saying, and educating them that, you're the old terminology, you're crazy. No, let's talk about what's going on in your life. And yes, based on all these things you described me that you're trying to juggle, you have a reason to feel the way you feel.
Right. One of the
Normalizing it.
Exactly.
One of the first questions I ask a client I'm sitting with is if they present with stressors, and which they often, if not always, do, what would your life look like if that stress were gone?
Yeah.
And I use that as the basis for my treatment planning. And just really, stress leads to all kinds of physiological and psychological issues. So if you address the stress, then oftentimes you take
So
care of
let's
the problem.
talk about the term, and I couldn't wait to bring this up, strong black man, strong black woman. I'm going to throw that out to the group, because I hear everybody, sounds like they have something to say about that. Carolyn?
Well, you know, we have, well, as far as our history, African-American females, we've always been deemed as the strong entity of the person in the family, the matriarch of the family, if you will. And everyone, you know, would come running to us with their burdens and their problems, and, you know, we put our mask on, and we have been able to handle it. So when we start falling apart, oh no, now the family is falling apart, but not understanding I need someone to lean on too. You know, I have some things going on as well. And so that perception that we can handle anything. Well, we do, and we try. But I think the tides have shifted that we realize, no, I can't handle it all, you know? I need to stop and take a moment and take care of me. And I think, you know, it really started, well, with the white community back with the women's movement in the 60s, that women realized, wait a minute, I don't have to do it all. I have a voice. I can advocate for myself. But we've been, you know, we would be silent with it. But now I think with education that we're becoming more forthright. Like, I'm not Superwoman. I can go to work, earn the bacon, but I don't have to come home and try to fry it up in the pan, juggle the child on this hip, and do all these other things too.
Right.
Yeah.
Right.
And Kwame, do you think that is, have you encountered that with any of your male clients of color?
Certainly. I mean, I work a lot with adolescents, so particularly in Cambridge through some youth programming and things like that. And one of the first things we do with my groups of young people, young men of color, is we try to redefine strength. So we talk about what strength means to them. And you know, it's a lot of the stereotypic responses: strong, like physically strong, really just I don't cry, I'm not emotive, those kinds of things. Those things come up, and of course sports metaphors and things like that come out. But none of them ever jump to you know, being expressive and being able to express my emotions in a productive way that's not doing harm to myself or others is strength. And so once we get to the point of breaking down those norms that they've been taught their entire lives, then we can do some real work, because it really opens them up. So I see that very often.
And now another question for you, specific to young men of color having additional stressors that other people don't have, being stopped by police, you know, having to worry about being in certain areas, being in their car, you know, those kinds of things. How do you kind of provide support to them around issues like that? Is that something that you have to provide support for?
Yeah, absolutely, especially with my young men, because a lot of them are experiencing those things for the first time, and they're just getting used to this world that isn't often unfair. But I got pulled over a couple of weeks ago, and I felt the same level of anxiety. So it's something that comes up with my adult clients as well. I think a lot of my adult clients get to a point of being desensitized, which is also scary, because you lose a little bit of your humanity when you get to that point, when you're not responding to this, and you take it as the norm. You know, yeah, this happens all the time. So it presents differently, I would say, but it's always present and something we have to deal with in therapy often.
Absolutely.
And Dr. Crawford, how, when you're listening to what Kwame says in terms of trying to, losing a sense of your humanity, how do you counsel people, or how do you support people in that specific situation? Because that's specific to a specific group of individuals who are dealing with this on a regular basis.
Right. It's really difficult, because especially when I have patients who are struggling with depression, one of the key features of feeling depressed is feeling like you don't have a lot of self-esteem, low self-worth, low self-confidence. And so when you go out into the everyday world and you're constantly being the target of a lot of these racist comments or being pulled over, and especially in the social political climate that we have right now, where it seems like it's constant. You're watching it on TV, when you go outside. And so when I meet with patients who have depression, depression, and I've noticed that they have worsening symptoms, I often ask them, what stressors have you been experiencing? What is it like for you to watch TV? What is it like for you to hear about all these different current events? How are they affecting you? And then oftentimes they start to share about that piece of not feeling worthy enough and not feeling seen. And it's especially difficult when you have depression that's underlying that, as well as this added layer of racism and oppression that we're constantly being exposed to nowadays.
We talk about the different types of stress. So earlier we were talking about more acute stress, but what you're talking about is chronic stress that we're dealing with all the time, and it's always present. And
Always present.
Right.
we need somewhere to process that, and a lot of times we don't get the help.
No. And Dr. Crawford made a good point about when you're asking them, what do you see on TV? What is it that you're seeing? When we think about it, when we see commercials or advertisement on depression, who do we see? We see white females. That's what we see. And then when we hear on the news that a white male has committed a horrific crime, the first thing they say, oh, he has a mental disorder, you know, something is wrong with him. Well, when you see a black or Latino and hear they committed a crime, they're a criminal. They're a criminal. So again, what do I do with my feelings of depression? What I'm seeing is it's only treatment for white females. What about black females? What about black males? And if I present as something, it's a criminal, not that I might have a mental disorder.
And Dr. Bhembe, do you think that there's less empathy for people of color struggling with mental illness?
Well, I would certainly hope not. I mean, I think in order to get
Or
progress,
perceived empathy?
Yeah, there certainly is perceived empathy, a lack of perceived empathy for people of color. It certainly feels like the understanding an individual, I think Kwame really sort of sets the stage when you talk about the interactions you have and how you begin the conversation, because it sort of opens up a dialogue, right? Who are you and what's important to you, rather than, well, let's figure out what clinical symptoms you have and then how you might fit this cluster of diagnoses. If you get to know someone and if that person feels like they're understood, they feel that the empathy builds the therapeutic alliance, which is the key in developing treatment long-term outcomes.
And do you think, being clinicians of color, that another person of color who may be struggling with a mental illness perceives that you have more empathy for them and that you are more in tune with maybe what they're going through?
Yeah,
Certainly.
definitely.
Certainly.
And that level of trust, you know, I think they feel they can trust us more versus the other people. You know.
Right, and they think you understand.
Exactly.
You understand. Oftentimes we don't. We may not. They may make assumptions that aren't accurate, but at least we get a bit of sort of groundwork with kind of coming in with a bit of trust that we don't have to build.
Exactly. And feeling that we're non-judgmental.
Right.
You know, they feel judged by the other people.
Right.
And also to feel like the clinician sitting across for them will have an understanding as to the impact that racism has on how they feel, on their mood, how it is they navigate the world emotionally. And if you feel like there's a barrier in place because the clinician is white or of another race, then that might actually hinder the ability to really kind of break through and to, you know, reveal everything that you've been holding on to. And that's why therapy is so important, and feeling like you have a connection with your therapist. And so if there's some kind of barrier that prevents you from sharing all of that, I can really see it interfering with treatment. But you bring up such a great point, because oftentimes my non-black clinicians would assume, oh, well, you know, she should see all the black people because she'll connect with the black people. But that's not true. You know, my experience as a black woman in this world is different from someone else who grew up down south, or someone else who's from, you know, Mattapan. I'm from Hartford, Connecticut. And we all have so many different elements of ourselves that make us who we are, besides the color of our skin. But if that's one way that people can step through my door, then I use it. And then I try to generate a conversation to really get to know them, because that's the important piece.
And more often than not, I've shared that experience with my clients, but there are those few times where being another person of color, being another black person in a small community in Boston, you know, folks have the reputation of, we have the reputation of talking and going out. Obviously, we're bound by HIPAA, but sometimes the client may not fully understand that and may not fully trust that you're going to maintain confidentiality, and that has been a barrier, particularly when I'm working with folks that are around my age range. When I'm with other young adults that might go to some of the same venues that I may go to unwind and decompress, they may be a little nervous about sharing.
And that's right. And two, that will cause, once they are willing to go to therapy and seeking someone of color, they may seek therapy outside of their community, because if I stay in my community and seek psychotherapy, well, you go to the same church as my therapist, know this person. Now, it may slip that I'm seeing a therapist, so let me go to Boston. If I live in Metro West, let me go to Boston and see someone, and hope your cross don't path, because that's still that trust factor. And I don't want everyone to know my business.
And I think it's really important to educate people in the community about what to expect if you were to encounter a clinician who's not Black, and to not allow that to be a deterrent to them actually seeking out treatment. So the majority of people from communities of color are not going to have a Black clinician or a clinician of color. So we need to educate people that despite that fact, that you should still seek out treatment and you should be heard. There's a lot of education on cultural competency. As a resident, we receive lecture after lecture about that. And so this new generation of physicians is learning how to treat everybody. And I think it's really important for patients to know that.
And so I'm going to just flip the script very quickly for anybody to answer. We talked about therapy being taboo and mental illness being a subject that's taboo. When you tell people what you do for a living, have you ever felt a certain way about how they responded to you? Carolyn?
Definitely. So especially when I first started, even with family members, they're thinking like, just because I may look at them, I'm psychoanalyzing them. No, I'm just looking at you. I haven't seen you in a while. And that, how do you do that? Are you safe? Yes, I'm very safe. And that you must bring that home with you. You can't just hear what you hear and not be affected by it. No, I work hard to leave my job at the job. And so that's why I go to the gym 4 days a week. Or that's why I'm happy I have the long commute, because I can put the music on and just leave what I just heard behind me, because I know that's important, not only but for me, but for my family, to leave my job behind.
Dr. Bhembe?
I'd agree. I mean, I run, and my husband and I go work out together, and it is an incredibly important part of our lives to sort of separate ourselves, because there are some intense and very heavy stories that people bring to you when they come in for treatment, and you want to be ready for that. And in order to be ready for that, you really want to sort of have cleared your own plate to do the work that needs to be done with them effectively. So yeah.
And in a casual conversation, have you ever, when someone asks you what you do, and you're like, oh, I'm a psychiatrist, what is that response like?
Oh yeah, it sparks this idea of, are you psychoanalyzing me? And are you crazy? What was wrong with you?
Dr. Crawford, is that the same experience you have?
Oh, absolutely. Whenever I'm at a social gathering, either people run away or they come up to me and they share all their stories. And it's really great. And also it's important for me to introduce myself as a psychiatrist in these settings, because they look at me and they're like, wait, you're a psychiatrist? But you don't look like one. And so, every day I'm able to kind of demystify what it is a psychiatrist looks like. And I think it's also important for people to know that even though I'm a psychiatrist, that doesn't mean I have all the answers and my life is completely perfect. I'm in my own therapy, and I think it's really important to know that, therapy is another way in which you can kind of deal with the stress of hearing these stories, especially being in child and adolescent psychiatry. You're working with families. It's really important to kind of use whatever venue or setting to unload some of that stress.
Right.
And Kwame, I think you have a minute to tell us a little bit about what the response is when you tell people what you do.
Sure. So Carolyn and I worked together over at Whittier Street, and one of the other clinical interns there is a black male, and we had this conversation. I was like, what did your family say when you got back in the field? You know, when you went back to school for psychology? And he's like, man, they don't think it's a real science. They don't think this. They're like, why don't you go back for your MD or something? You know, so, you know, and going for your PsyD, it is a science. It is it's certainly a field that needs to consider physiological symptoms and be aware of that. So I get a lot of that push that you know, maybe it's a fake science or this isn't real, it's not real health issues.
But you are all here to say that it is very real.
Yeah,
It's
good health
absolutely
is
real.
not good health without mental health.
Excellent. Thank you very, very much. Thank you to all of my guests here. We're going to continue this conversation on Facebook because I have many more questions. Stay with us here. We will be right back on Facebook Live. Thank you so much for joining us here on Basic Black.